spaces.
Scapulohumeral joint. And then what was the landmark again? Glenoid cavity. Yeah, so that's going to be an overlap there.
What else can you do? There's some great anatomy on there. It's a good practice image.
Let's see. What's this joint over here?
AC joint.
AC joint. And what end of the clavicle is this?
Acromial.
Distal end or the acromion end of the joint there, or of the clavicle there?
Distal, it's not distal.
This part?
It's more, well, I typically can say distal, but they're going to say the more, it's the more lateral end, based on the habits of the body, position of the body, because you're going more laterally.
What about this piece of anatomy right here?
The coracoid.
Coracoid. What's the name?
Is that an optimal radiograph,
No.
based on the criteria we just named?
No.
Why would that not be optimal?
Clavicle is cut.
You are correct. Say that louder.
Clavicle is cut off.
On which end?
The medial end.
Sternal.
External ends. So once again, keep in mind, guys, because you're going to see these even in your book. That's not optimal. You can probably still send that in and be okay, but for optimization, you need to see what? The sternal end, the entire sternal end. To be safe, you just want to include that as C joints.
Melanie had a question.
Sure, for one of you wants to go ahead.
I was gonna say, did they include too much humerus on this one? Is that why they missed
No,
the?
it's not too much humorous. It's just they
Just didn't center properly?
They collimated horizontally a little bit too much. It's just barely clipped.
Okay.
Melanie, you had a question?
Can we also say medial end, or do we have to say sternum? Yeah, sternum.
It's I would already say sternal and acromial ends. That's what they're going to use.
Alright, next position we're going to go over is that external rotation. So we're going to have our hand go external. Same position, we're going to be supine or upright. Arm is going to be abducted from the body slightly, so we're going to move it slightly away from the body as we turn and rotate externally with the hand supinated. And that's going to place our epicondyles parallel to the IR.
I want you writing that down. That is very important.
So we know where those epicondyles will be in relation to the IR. Very important piece of information there. And as we turn that hand, get the epicondyles parallel, what piece of anatomy are we going to be putting in profile? The greater, yes. Greater tubercle is going to be in profile on this position. Know that as well. If I'm moving too fast or anything, if you guys want extra time on the slide, just let me know.
All right, back to anatomy. Here we go. This is the shoulder girdle.
Something's up with this clicker here.
It's like it's glitching.
Huh?
It's glitching or something.
Since you just keep trying to test.
But it's glitching because you guys are so rough with it. You guys like. No, like I see y'all, like you guys go like this, like, cause it's just not working. It's like you guys are definitely more.
Just give me one of those old school pointers, like the long stick.
Oh, with that little finger.
Oh
No, that's gonna be like, Melanie, wake up. Okay.
Alright. Is everybody good?
Mm-hmm.
Alright. So the central ray, again, we're going to be perpendicular, and this is going to be the same centering point for the CR, for the central ray. It's going to be 1 inch below the choric process, 1 inch inferior. So as you're positioning this patient, all you'll really have to do, if you're moving them from external or internal to external or vice versa, you're just going to have them simply rotate that hand depending on where you're, which position you're doing. IR is going to be 10 by 12, same thing. We're going to be doing primarily crosswise. half an inch above the shoulder, half an inch lateral to the shoulder, as far as the light field. And again, we're going to want to make sure to include the sternal end of the clavicle and the proximal third of the humerus. So same thing as the internal, all we're doing is just simply rotating the hand outwards and putting that greater tubercle in profile.
Make sure, guys, that you're really paying attention to that central ray, because one mistake I always see people make on their exams is they mix up the AP shoulder with the AP scapula with centering. Y'all remember from lab, where do you see different AP scapula? Wow, we really paid attention in lab this week. That's the stop sign, guys. AP scapula is the stop
2
sign.
inches below
And
the.
like 1 inch inferior of the lateral and 1 inch medial.
I'm talking about the AP with the stop
Oh,
sign.
the eight
Stop.
mid
Oh,
scapula.
I wouldn't do that.
Where is it, guys?
It's somewhere right here.
Isn't it 2 inches
My
below the?
fingers.
Oh, 2 inches.
2 inches inferior corticoid. So your shoulder is 1 inch, scapula 2 inches. Make sure that you're careful with that and pay attention, because that's always something people mix up every single year.
As long as I get this right.
Can we palpate somebody, like, you know, sort of at the end of the outfit to see where the cortical is? Cause like, I really don't.
Can you palpate to see where the corticoid is? Of course you can.
No, but like, can we do a demonstration?
Oh,
Yeah,
yeah,
yeah.
sure,
Yeah, of
sure,
course.
absolutely.
Looking at me crazy.
I said I volunteer at Johns' tribute.
So this external rotation here, this is a good image of what that would demonstrate. Humeral head in profile, and the start of the show is going to be that greater tubercle out here. You're going to see that in profile. Lesser tubercle is not going to be in profile here. It's going to be superimposed.
We're seeing that difference, by the way, guys, between that greater and lesser tubercle being in profile. It's very important to start identifying that.
So the greater tubercle is always going to show up more laterally.
It will only ever be lateral. And lesser will only ever be in profile medially.
So the greater is like a meter from that, this sticks out more. So can you look at it like that too?
Does the greater stick out more? Not necessarily. They're pretty similar, actually. Just depends on how we're turning that arm.
And scapulohumeral joint is going to be visualized there with some slight overlap of the humeral head. So the anatomy is pretty labeled on this: clavicle, acromion, corticoid.
Is that optimal?
Bless
What?
you.
Less.
Why would it not be optimal? Sternal end of that clavicle is not shown here. It's cut off there.
And that digital marker. Ugh.
Isn't it gorgeous?
Look how sharp it is. My goodness.
It's so visible.
The contrast.
Isn't it gorgeous?
It's
Texas don't actually carry their markers anymore, cause I don't think they don't come out with any markers at all, cause it's like, well, based on the ones I've seen, they don't carry them, cause they're always chasing me around. Yeah, water marker, can I see your markers? Can I see your markers?
Yeah. On top of the bucket.
That's called being lazy.
Yeah. Some do, some don't.
Yeah, they have some. Yeah.
Or some don't stick.
I haven't seen them.
Oh yeah, you'll see some texts that, you know, they carry their markers. They have like cool custom markers too.
Yeah, check
She
out
has a
Etsy.
whole set.
Whenever you're on
Victoria.
set, check out Etsy, you can get all kinds of custom markers.
Oh yeah.
It's really cool.
But she didn't have any that has that stick,
Thank
so
you
she only
so
used it on
much.
like
Hand,
flat surfaces.
Are we allowed to get custom student markers or?
No, student markers are just the regular markers that they give you. Once you're a tech, you can get whatever you want. All right, everybody. So AP projection in a neutral position. This is for our trauma cases. We're not, if we're in a trauma situation, we're not going to want to manipulate the patient because they could potentially make any problems that they have worse. So we're going to leave that arm in a neutral position. And if they can, just have them just place the arm right there, the hand on the thigh. And that's gonna place our epicondyles in a 45-degree angle to the IR. Central ray, our centering is gonna be exactly the same as the previous two positions, and we're gonna collimate the same way as well.
You know, please don't touch the arms if they're
Yeah.
like in a trauma room, like you're in the shock room. Don't go in there and start trying to turn that patient's arm. If the bones are sticking out, it's deformed, or it's dislocated. You're not gonna make the patient mad, you're gonna make the doctors mad too.
You could seriously injure someone messing around with their arm in any trauma situation. Yes.
Neutral position is the same as neutral rotation.
Yeah. There's no rotation. It's just neutral.
What's a neutral rotation? Humerus. When we say neutral rotation, humerus, it means the neutral position.
Neutral position. Neutral position. And this is how that would look. As you can see, the greater tubercle nor the lesser tubercle are in profile here. They're both superimposed. Humeral head is seen in partial profile. Still has some overlap between the humeral head and the glenoid cavity there.
Is that optimal?
That was going to be my next question.
Sorry. I'll shut up.
Okay. So is this optimal? No? Why not?
SC joint, visual marker.
SC joint digital marker. Same as the others. Is this some Merrill's?
This is Mills. But every book I've ever seen, almost every Google image, you'll see them over collimating like that. Even though they state that the optimal visualization needs that SC on there.
All right, we're gonna go ahead and go to our AP oblique, also known as the Gracie method. Patient position is gonna be supine or upright. And we're gonna oblique the patient, so we're gonna have them in an RPO or LPO position, depending on the site of interest. We know that degree of obliquity, 35 to 45 degrees oblique. And it is a posterior oblique. We're gonna wanna put our affected shoulder, the side of interest, closer to the IR. So if the side of interest is the right shoulder, how are we gonna oblique them?
RPO.
What was that?
RPO.
RPO, yes, correct,
What's the other?
correct. So right side RPO, left side LPO. Pretty easy to remember, hopefully. And rotation, as we rotate them, that should place the scapula parallel to the IR. And as you see, we're gonna place that arm across the stomach for this position.
And do make note, it's only an RPO and LPO, guys. So there's no REOs or LEOs. You may see some techs doing those, REOs and LEOs, but optimally, ideally, for the curriculum, you should only be doing LPOs and RPOs.
Central ray is going to be perpendicular to the glenoid cavity. And it's going to enter 2 inches medial and inferior to the superior lateral border of the shoulder. Collimation size is going to be about an 8x10. If we're doing this crosswise, which we normally do, about 1.5 inches above the shoulder and 1 inch of light lateral to the shoulder.
And there's a little trick to that too, guys, because you're probably looking at that central ray and saying, sense, how would I figure out what that is? You can basically just center for an AP shoulder, inch below the coracoid, then move on to the oblique, and it's gonna be that same entrance point. Does that make sense? So put in the AP first, you're 1 inch below the coracoid, then oblique them. Little cheat code pro tip there.
Texture. We got on that, guys? Good. Alright, so this is what that image is going to look like. And we're doing this primarily to see the joint space here, that scapulohumeral or glenohumeral joint. Nice open space there. We're going to have that cavity in the profile. So that's going to be the star of our show, and that's how we're going to be doing this position primarily. So based on the criteria that we have, is this a good optimal image?
No.
No?
I mean, it looks good with the marker.
Yeah, digital markers there. But besides the marker, would we say this is positioned correctly?
I would say.
Yeah? Okay, yeah. Pretty good. Main star of the show is that cavity there, so if we're seeing that cavity, that's going to show that we properly oblique that patient. If it's closed off, that either means we under-rotated or over-rotated the patient.
Is it centered correctly, or is it a little off the x-axis?
It's centered pretty well there. Maybe slightly off, but it's not anything we would repeat for.
You can always optimize it a little further, do a little more medial, but as he said, you wouldn't repeat that. It's pretty close.
Next position that we're going to go over is another trauma position here. That's the transthoracic lateral. And this is going to be for patients who are not going to be able to rotate or abduct their arm. So I'm sure this is one of the positions you did in class, or did in lab, correct? So supine position or upright lateral, depending on patient condition. The affected side we're going to have close to the IR to minimize OID, and the unaffected side is going to be raised over the head. So we're going to be shooting through the body to look at the humerus, or to look at the
Before he moves on, I want to make one point here, guys, to make sure we're not confused. This is not the same as the transthoracic humerus. This is for shoulders. There's a transthoracic lateral proximal humerus, essentially, not the entire humerus, like the one y'all did in lab. It's a whole separate position that we're going to talk about later. This is proximal humerus only. It's a Lawrence method.
So for our positioning, the affected side, we're not going to be moving that at all. And the non-injured side, we're going to have them raised straight up to get that out of the way and not superimpose it. And on this position, we're going to be centering to the surgical neck of the humerus to the IR.
So, Mr. Hernandez, is there like a little technique to this X-ray they need to be aware of when it comes to like centering for these and the collimation? There's some things, if I recall, some things that throw us off on that if we're not careful.
Some things that can throw us off.
Yeah, so it's collimation and centering.
Yeah. So because of the OID here, the light field is actually going to look smaller than it really is, and we're centering to the surgical neck, which would primarily be, you would think, up here or so. But because we're raising the hand and because of that OID, the light field, it's going to have to play a trick on you, so it's not going to look exactly right. So what you'll want to do, you'll want to have that arm down, find your centering first, and then raise the arm up. Does that make sense?
Yeah.
Yeah, because a lot of people go in there, it'll look really small, so they'll start playing with that collimation. Like,
Yeah.
oh man, I'm gonna miss it. But as he said, it's playing a trick on you because the torso is so thick, it's making that light field look smaller than it actually is. If you move them away, you'll see that it has that full collimation on the actual IR. It's a little optical illusion. question?
So we won't really be able to like collimate it since we can't really see. So we will open it up all the way.
No, not necessarily. You can still collimate. It'll be off visually, but you can look at the numbers on your collimator box to make sure you're still within the right collimation fit size. Although in clinic, you'll probably just keep it open. It's the truth. But you're gonna want to collimate, you know. All right, perpendicular central ray. We're going to be entering at the MCP, at that surgical neck. And again, make note of that. The light field is going to appear smaller on the skin because of the OID. Do not open up that collimation. It's a visual trick. Light field is going to look smaller. That doesn't mean you have to open up the collimation larger than the IR size. Respiration on this is going to be on inspiration, where you're going to use a breathing technique. That's their orthostatic breathing, which is essentially just breathing normally. And when we do that, we're going to set a technique to make the exposure time longer so we can blur out the ribs, so we can see the shoulder anatomy. Yes, Mr. Donahue.
What's the purpose of the breathing technique? Like, why would you want to do that?
That's a good question.
Are you asking us?
I'm asking Mr. Hernandez.
So,
I
That's a
don't
good
know.
It's a good question.
I think
Class.
that's asking you.
He's asking you.
He's asking me?
That's what he
Mr.
said.
Hernandez.
Why
Is there another Mr. Hernandez?
I think Mr. Hernandez said it was to blur out the ribs.
Thank you, Jay.
And the
I'm sorry, my hearing's going out. I apologize.
Thank you,
I
Jay.
was
So,
checking Facebook, you know, I wasn't paying attention to class.
thank you, Jay. So yes, we're gonna be using that orthostatic breathing technique so we could blur out the ribs. Otherwise, we're gonna have ribs superimposed on our shoulder anatomy that we're looking for. Great question.
It's a really good
It's a
question.
really good
Yeah,
question.
yeah, that's a really good question.
what's the word you use?
What was
Orthostatic.
that?
The blur out the
Blur out the
Yeah, so we're using
motion.
orthostatic breathing. Yes, which is basically just breathe normally. That motion as you breathe, that's gonna move the ribs, kind of blur them out. Yes, Jay.
So it's similar to our heart shadow. We can't stop our heart, so it always creates this blurred image.
Similar in a way. That motion will create a blurred image.
That's something to do with the breathing. I don't know.
He was serenading and he exposed.
Yeah, and then I was like, looking at him like, okay, well, I'm supposed to,
What is it?
you know, push the button because like, it's red.
Yeah, so as you do that orthostatic breathing, you're gonna blur out the ribs.
Now that it didn't see the ribs.
I heard the,
So there you can see the shoulder better.
Ah,
yeah, that's the rope.
He was doing that. I was like,
he's so serious too.
Fun. Alright, so here's what our transthoracic is gonna look like here. We're looking at the shoulder and proximal humerus through the thorax. And since we're going through the thorax, you're gonna see those ribs there. But with that orthostatic breathing technique, they're not gonna be as prominent. They're gonna be a bit blurred out as to let us visualize the anatomy that we're looking for, which is gonna be our scapula, clavicle, and humerus.
They usually don't look that pretty. You can see on that picture there.
They usually don't look that good.
What's the main reason we do this X-ray?
trauma.
Trauma, that's your key word. So if you had a situational question that said, patient has arrived in the shock room, flat on their back, on a stretcher, the arm is visibly deformed, cannot be manipulated, what trauma view would you include on your shoulder series? What trauma views, rather, what trauma views would you include on your shoulder series?
AP neutral.
Lawrence and what else? Lawrence and Lawrence?
AP.
Now you do,
What was one of the positions we already went over, guys? The neutral, the neutral shoulder.
Neutral shoulder and Lawrence are going to be your traumas.